Good afternoon, ladies and gentlemen. This is Noha Hassan. It's my pleasure and honor to be with you today. And I would like to welcome you to our session today of the Saudi Patient Safety Center Conference. It's about a very hot topic, diagnostic safety in different healthcare settings and services. So why diagnostic safety and what's so unique and special about diagnostic error? Diagnostic errors occur in all settings of care. It contributes to about of 10% of patient deaths. So it's a very high risk type of errors. And they happen in different settings and areas, and starting from the primary care, reaching the tertiary care settings. I know Harvard have done many research on that. So today we have a very unique speaker and Dr. Gordon Schiff, who have been very interested in diagnostic safety. Dr. Schiff is a practicing general internist and associate director of Brigham's and Women's Center for Patient Safety Research and Practice. He's an associate professor and quality and safety director for Harvard Medical School Center for Primary Care, and he has published widely on medication and diagnosis safety. He was a reviewer of the 2015 U.S. National Academy of Medicine report Improving Diagnosis in Healthcare. He has authored more than 200 papers and textbook chapters, including articles detailing conservative prescribing and diagnosis principles and practices, and the recent Harrison's textbook chapter on diagnosis safety. He chairs also the editorial board of the medical care. In addition to that, I would like to say that Dr. Gordon is a very kind, decent, humble, and approachable person. I've been experiencing interacting with him as one of my professors when I had my master's, and his session was the most informative and enjoyable sessions. So please welcome Dr. Gordon, and Dr. Gordon, the mic is yours.
Thank you for that kind introduction, but the credentials that mean the most to me is the last comments you made. Thank you. I should try to be personal and humble, and we'll do our best doing this remotely. I'll go ahead and share my screen if that's going to work here. And then we hide this. Let's see, where's my, how are we doing? Are you seeing my PowerPoint here? Is that right? Swap displays. How does that look, folks? Does that sound okay? Look okay?
Yes.
Okay. So I guess we're going to spend the next 25 minutes or so walking you through things that I think you've heard from different vantage points, but I'll sort of give you my journey, beginning with my disclosures, which I don't have any commercial. We've had several foundations and the malpractice insurer, AHRQ funding our work. So we'll give you my sort of background way of thinking about diagnostic errors, why they're important. And I've provided you with 13 tools that hopefully will allow you to continue to do work in this area on your own, talking about diagnosis as a system and how we can really practically approach this and make things better. I was just seeing a little bit of the previous talk that I think you've gotten a lot of these suggestions before. So this will reinforce it and give you my perspective. This was, I think, a pivotal moment in the diagnosis, learning, and promotion field of this being an important problem. Now it's, we have 6 or 7 years old. But if you go back just right around the time that was coming out, there was a survey done earlier that said, did you have an error, someone you close to you personally have an error? And a quarter of the people said yes, but this is what was the surprise. Diagnosis was number one. This was hardly on the radar screen for the patient safety movement, but you can see more than any wrong surgery or wrong medication. The National Patient Safety Foundation and IHI, which your previous speaker was part of, they asked a little broader question. Have you personally or someone else you've known experienced an error? And here we talking about 40%, almost half of the people. But look at the ones that were given. Misdiagnosis was number one, and actually diagnosis didn't make sense. So again, this is telling us and telling the field, which really didn't appreciate diagnosis, errors are really important. And then if that isn't important enough, they began to survey patient safety leaders. This is in the US, this is ECRI organization. And starting in 2018, they did a survey, and again, lo and behold, among all these other problems, of course, we know they're all extremely important. Diagnostic error was number one, 2018, 2019. There we are again. Test result management and diagnostic stewardship. I think you had a talk on test result management. 2019, again, same findings. And then here we are in 2019. And then COVID came, and diagnosis is sort of nowhere on the list, emergency preparedness and pandemic preparedness. So somehow this sort of dropped off the radar screen. And now here we have 2022, where even the staffing shortages and COVID is high on the list, but cognitive bias, diagnostic error is still there and coming back into view. We did a study where this talk is about primary care. We took all the primary care malpractice allegations of the two leading insurers in Massachusetts, Crico and Coveris, and there were roughly about 100 a year, 500 over a 5-year period. And again, really surprising the dominance of diagnosis related. So really of the 500, roughly 400 were diagnosis error. Look at how compared to medication treatment, the next medication and treatment related, the next category, almost by a factor of 6 or 7 to 1, diagnostic errors dominated. What were these diagnosis errors that we looked at? We found when we looked at these claims, cancer, really high prevalence of cancer. We talk about these big 4 cancers: colorectal, lung, prostate, and breast. I just say as an aside, we've just gotten funded by HRQ to start meeting with patients and hearing their stories and actually not being afraid. We're looking at this with full apology and disclosures. What really went wrong with these cases? Hopefully they don't end up as malpractice claims, but really as learning opportunities. And this is why we think there's really opportunities to learn. Let's take a second to orient you to this slide, but this is all the malpractice cases, 6,600 cases, and about 20% of these are what they call settled. So in very oversimplified terms, the lawyers look at this case and says, oops, we did something wrong. We better just tell the person filing this claim that we're going to settle with them. And look at diagnosis cases, 39% are settled. Okay, even the ones that come to trial, this 1% are lost. People talk about patients suing and doctors losing, but actually that rarely happens. But even twice as many, 2%. But what this means is 39% is somebody is looking at this chart and said, there's really things that we could have done better. And we're not going to argue or fight with the patient. We're going to settle this claim. And so this is the opportunity for us. This sets the stage for what we're going to talk about here. So now we know as practicing primary care clinicians, this is no surprise that we're up against some major challenges. Time limitations, I think we just heard about that as being the first question in the last talk about how we prioritize, how do we deal with the limited amount of time. But in some ways, it feels like things are getting worse. There's no time to think, talk to our patients. Another challenge is that it's not just us doing the quote doctor's job, but diagnosis is really a team effort, and these systems have to work properly, handoffs, growing complexity of diagnosis, uncertainty. These are all words we could spend the whole hour talking about. Discontinuities, there's lots of data about how things are getting worse in that regard in our country. Communication challenges, people are not getting access, health insurance, and then now we have COVID and virtual visits. And then this whole idea about doctors relying on their human memory, which is a very weak link for safety, and payers telling us we got to do less tests, less referrals. So I might be worried about something, but if I order too many back MRIs, and then that's going to count against me. So how can we improve diagnosis? I have these two very big words. There's a lot of meaning behind each of these, but situational awareness, being aware of the problems, and then creating safety nets. So how do we do that? How do we create an awareness of the pitfalls and design reliable safety nets to prevent and mitigate harm from diagnostic errors? So one of the ways that we've been approaching this is really looking at primary care cases, one case at a time. So every month we have a group, it's called PRIDE, Primary Care Improvement in Diagnostic Errors, where we meet really nationally. We have a virtual conference where we present cases, and we've written this up, and I've given you the first tool is really how can we sort of bring in these cases and just format these. And so I encourage you to take this tool, and I have my students fill out a case the first day we meet of a diagnostic error of their family or someone they know. And it's a way of structuring and thinking about these cases. Again, ultimately, we've written up about a dozen of these cases in what's called the HRQ Web M&M. So we have a recent one, for example, a patient with recurrent pneumothorax. I'm not going to tell you the diagnosis that was eventually missed, but this was a rare diagnosis, but most often these are more common diagnoses. And again, these are all free on the internet. But the second tool, really, you've seen a lot of figures from the Institute of Medicine report, I believe was just shown to you. But my simple mind, my humble mind, just needs to boil this down into sort of three simple Venn diagrams. So this is something that's going wrong in the diagnostic process. Let's say the patient in bed 36A has their blood sample mixed up with the patient in 36B, and sodium comes back abnormal that you wouldn't have expected for that patient. It doesn't necessarily lead to any misdiagnosis of hyponatremia. You repeat this blood draw and it comes back normal or adverse outcome. But what about Linda McDougall? And I'm not violating patient confidentiality. She was on the cover of Newsweek magazine. She woke up from her breast cancer surgery. She had bilateral mastectomy. And the doctor said, "You don't have breast cancer." The surgeon and the patient said, "Thank you, doctor, for cutting it all out, for removing my breast cancer." He says, "No, actually, we realized you never had breast cancer. We actually mixed up your specimen with another patient." So she obviously had a diagnostic process failure. These happen all the time. But in her case, it led to a misdiagnosis of her having breast cancer when she didn't, and an adverse outcome. And so obviously where these circles intersect, and they're intersecting tens or perhaps hundreds of thousands of times a year in our country, that's what we're concerned about. But obviously focusing on some of these process failures to prevent this from occurring. So we've created a tool, and this tool number 4 through 7 I think are going to main tools that you want to take. This is called the DEAR taxonomy. And this really allowed us, we were trying to meet, we couldn't even agree whether there was an error or what caused the error. So we took a step back, and let's just start with what you start with in medical school, anatomy. So what was the anatomy of what went wrong? Where did it happen in the diagnostic process? Did it happen in access or history, physical exam, etc.? So this tool, I think, was an early tool that allowed our field actually to move forward by putting this lens on just sort of where in the diagnostic process. And of course, in many cases, multiple things were checked off. The next tool is why. And again, we wanted to be modest about this, and we didn't want to say we can tell exactly why this diagnosis error happened, but these are some of the challenges. So we call them an RDC, reliable diagnostic challenges. Atypical presentation, or outside their specialty, or there was a masking diagnosis that mimicked it, patient factors, language problems, testing. And we have data, which we're not going to have time to go through how many of the things fell into these different categories, but diagnostic pitfalls. So how are the things can go wrong? We'll come back to this as be a major part of what we talk about in terms of improvement. And then how do the clinicians' thinking go wrong? And this is sort of a very simple list. You look on the internet, there's hundreds of these cognitive error, biases, heuristics, but these 10 simple ones, we've tried to boil down this list so you could remember. This is often now being taught to medical students, how to avoid premature closure or availability bias. See a dramatic case recently, so you're going to think the next case is going to be something dramatic like that, and etc. Of course, this is a very important one, stereotypes of personal beliefs about women or minorities, prejudices that can get in the way. And so one of the reasons we think this diagnostic taxonomy is important is it helps us understand individual cases better. So it helps us dissect these cases as we talk about them, to summarize it. It says we're not somebody to blame. You see the bigger picture. Helps us to connect across cases. Okay, so it's not just an isolated case. And then obviously helps us with the situational awareness, preventing errors, and also is a cultural guide that we really, a way we think about errors. And so what are we going to do about this the remainder of the time? I mentioned the report from the Institute of Medicine. They had 8 goals, 8 approaches, and I'm going to sort of even simplify these further, but one is more effective teamwork, handoffs involving families and professional education. I guess you'd say that's partly what we're doing here. Health IT, we'll mention that. Learning from errors, establish a work culture that system that improves, develop a reporting so people aren't afraid with these malpractice cases before they come to that, payment systems, and then more funding for research. So I boiled this down into these 5. So create a culture of diagnostic safety, learning from cases, closed loop systems, leveraging health IT, and then engaging the patient. So let's just walk through these quickly one by one. So we heard this term was in evidence in your last talk, probably multiple talks. So you think about this every day. But number one, no one should be afraid to ask questions about the diagnosis. Instead of nurses just listening to the doctor's diagnosis or even the patient's, people should be able to question these. And then when things go wrong, sharing them. So replacing fear and blame, again, central thing in patient safety. I don't need to belabor that with you, but we're putting this into the diagnosis lens and an organizational commitment to learning. So frankly, there's very little being done at the organizational level, even though this is the number one cause of patient-reported error. As we said, we should be obsessing over the details of all the things that go wrong in the diagnostic process. And then recognizing the uncertainty. We heard the word ambiguity in the last talk. It's often not clear what the diagnosis is. And so we need to be able to tell patients, not that we know all the answers, but they need to work with us, respecting human limitations. And if I have 10 minutes to see every patient as opposed to 20 or 30, which I need, then and the EMRs have to be redesigned and then involving the patient. So there's actually a way now of measuring this culture of safety. This is a tool that we've included. This just came out a few months ago from AHRQ. So just like you have an instrument, you can measure length or weight or pressure or temperature here. This is an instrument that you can take to your office. And I was part of designing this. I'm not even sure everything is perfect here in terms, but these are sort of generally, is there enough time? Do they have time to finish their notes and do them in a good way? Testing, again, I'm going through this quickly. You'll have these tools yourself. Do we track the results, even if it's normal? The results, does it get back to the patient so the patient can know to expect this? How do we deal with referrals? Do we track referrals, especially if it's high priority, that make sure they get done? We just completed a series of studies. Maybe 15 to 20% of referrals for skin cancer never get seen. The patients, that referral never happens. So there's a lot of balls dropped. And then finally, again, this just communication around diagnosis. You know, when a provider thinks this, misses a diagnosis, do they share that with other people? And again, you can use these tools to measure the culture in your offices. This is a new concept we call diagnostic pitfalls. And so we heard about high reliability organizations where people worry about what can go wrong, making failures visible. And so we've come up with this concept where we've been trying to promote diagnostic pitfalls, clinical situations, patterns vulnerable to errors, missed, wrong, or delayed diagnosis. Now, this is hardly an original idea. We went back, we found this is almost 110 years old, study of diagnostic pitfalls from 3,000 autopsies by Cabot, who started the CPC in New England Journal. But here we are, hemorrhoids, often mass cancer of the rectum. And so what are the sort of the pitfalls? So we went on a quest. We looked almost at 1,000 cases from a variety of sources, and from malpractice cases, incident reports, and you'll see in this article, which we just published, again, is available open access, from focus groups with specialists. And we came up with what we call generic diagnostic pitfalls. So one is disease A mistaken for disease B. So like aortic dissection, misdiagnosis of QMI. So to understand that that's situational awareness, or bipolar, misdiagnosis, depression. This is sort of a classic one. A woman comes in with a breast lump, and the doctor agrees, palpates it, sends a patient for a mammogram, and it's normal, and says you don't have breast cancer, you don't have to worry. Well, we know that that's false negative 15%. In fact, I can give you some data here. Aortic dissection, 34% of the time is misdiagnosed when the patient comes in with chest pain, because people think about that first. Bipolar, even higher, 65% of the time is misdiagnosed. And these have different treatments, radically different treatments. Thrombolytics is not a good idea in dissection. Breast lump, as I said, 15% of the time, a mammogram in the face of a palpable breast lump is going to be negative. And again, we could go through all these, but atypical signs and symptoms, sepsis in the elderly, they have no fever, so you don't think about infection. Well, we know that's not true. Failure to understand the urgency of the diagnosis. Actually, I got one more here, 28% of COVID, we know testing now is not 100% sensitive for sure. And then the last generic group of pitfalls, the drug or environmental factors overlooked. So somebody has ventricular arrhythmia and they don't suspect the QT drug. Failure to appreciate the risk factors, not getting the family history. Failure to appreciate the limitations of physical exam, especially now with telemedicine, et cetera. So what if we had a section in the Harrison's, we have a chapter in there, but for every disease, you have the clinical features, differential diagnosis, and diagnostic pitfalls. There ought to be a section in every disease there. Or what if we could have hit Alt P while we're typing our note, and we'd have context-aware pitfalls would come up on the screen, things to remind us. I don't think there's any reason in theory, technically, or conceptually why we shouldn't be able to do this. Here we have a tool that collects all the pitfalls that we've seen in COVID. Originally failure to consider it. I don't think that's as likely, but atypical presentations, false negative tests. And then we have non-COVID diagnoses. People can present with an MI and COVID. Again, we have a whole talk we've do around this, but you have this tool at least to orient you. And again, high atypical presentations, 40% of the patients present with some of these other, it's not just somebody with shortness of breath, a typical pneumonia picture, and even asymptomatic, you could say that's atypical. Patients initially stable, et cetera, drug interactions. So why are pitfalls going to be helpful to us? Facilitates thinking about errors in more clinically oriented ways. Hopefully you're finding my comments very clinically engaging for clinicians. Lets people be less defensive, helps provide us change stimulus. It's a framework for conversations with specialists, and then practical levers. So we could educate doctors to anticipate these sections in the textbooks we talk about, electronic decision support, as I mentioned, identify these situations to design guardrails and process redesign. It's a framework for collecting epidemiologic data. Which ones are more common, more deadly or harmful? Inform triggers for searching for these. And then patients should come in and have these pitfalls, and they would know a list of things. Doctor, are you sure you haven't failed to consider one of these pitfalls? So
Gordon, not to interrupt you, but we need to wrap up.
One more time. Yeah, 5 minutes, 10 minutes, what?
You can go with less than 5 minutes.
5 minutes. Okay, so we have the red flags. Okay, if people can know what those are. We have don't miss diagnoses. So these are, again, concepts of things that are rare, rapidly progressive, remedial, and really bad. Spinal cord progression, tamponade, tension pneumothorax. We should be considering these rare ones. And then 4 C's, don't miss diagnosis. Contagious, continuing exposure. So you don't want to send somebody out with, a viral URI when they have TB because of the consequences. So we've compiled a list of these. It's in the textbook of some of these things we've just mentioned, but this is a very, in some ways, a sort of a short list of don't miss diagnoses that are illustrations of this. So putting all this together, so you have red flag symptoms, you have don't miss diagnoses, and you have diagnostic pitfalls and how to create a conceptual and practical way. Closed loop symptoms is where the water goes on every day, open loop, and it's regardless if it's raining. So we need to create these closed loop practices. That includes giving feedback to the doctors. We tried to automate this with automated calling and found a lot of patients had not improved. They never followed up with the doctor. There were a lot of misdiagnoses there. it conveys to the patient that we're not certain. We want to follow up. We have a differential diagnosis. And then I'm going to go a little quickly, health IT. We try to see how can we have the health IT not get in the way, but actually help us. And we've given you two articles. But it's not just to sort of cover your body after you do the encounter, but really CYA should be a canvas for your assessment, where you're weighing the degree of uncertainty and urgency, differential diagnosis. That's what these notes should be, not a lot of check boxes. And we've created these categories of ways this health IT can help, again, for the sake of time, but help gather information, organize it in visually helpful ways. We don't have that right now. Generating a differential diagnosis, help us weigh these, help ensuring hardwired these closed loops, remind us of screening that needs to be done, and even feeding back about diagnoses that emerge so I can learn from my mistakes. Final one of these 5 is engaging the patients. So patients need to obviously seek timely care. They have to help us report these symptoms, sharing their hunches. A lot of doctors say we don't want to hear these patients have crazy ideas. I think we should be welcoming anything the patients are concerned about, grappling with uncertainty, respecting limits on time and staff. And question is, what will it take at the provider and institutional level to support these roles and help these do it? So to summarize, we have 3 questions that you should be asking yourself. Really, with each patient, what else might this be, forcing a differential diagnosis to be made? Most of these malpractice cases had no differential diagnosis in the chart. What doesn't fit? What are abnormal findings that don't really fit with the diagnosis I'm making? Somebody has back pain. Why do they have anemia? That doesn't seem to fit. What critical diagnoses are important not to miss? That's where we talked about these don't miss diagnosis and red flag. And then 3 system problems. Do we have reliable systems for closing the loop, making sure these abnormal labs or the referrals we're making are getting carried out and followed up? What's the safety culture in our office? I showed you one way of measuring this. And then how does the EMR help us versus get in the way, and how can we redesign it? So thank you very much. I've given you some of these background readings here, and I think hopefully we've come in within our time frame here. Thank you very much.
Thank you so much, Dr. Gordon, for a very informative lecture. And please be with us for the end of the session for a Q&A. Next, we have Dr. Kumal Bajaj. Welcome, Dr. Kumal. Dr. Kumal is an innovator and healthcare leader based in New York City. She serves as a Chief Quality Officer for NYC Health and Hospitals, Jacobi NCB, as well as Clinical Director of NYC Health and Hospitals Simulation Center. She was an inaugural National Academy of Medicine Diagnostic Excellence Scholar and is a member of the Agency for Healthcare Research and Equality National Advisory Council. Dr. Bajaj is a professor of obstetrics and gynecology at Albert Einstein College of Medicine. She is double boarded in OB/GYN and clinical genetics. She has published over 50 peer-reviewed manuscripts, serves on several editorial boards, and is an internationally recognized speaker in topics such as ingraining equity into quality and safety processes, applying a diagnostic safety lens to maternal mortality reduction and health simulation as a quality safety technique. So please welcome Dr. Kumal. Dr. Kumal, the mic is yours. Thank you.
Thank you so much, Dr. Noha, for that introduction. And it's such an honor to be with all of you today. And I'm very honored to be, sort of on a slate with such recognizable trailblazers of speakers. So I'd like to talk to you a little bit about adding a diagnostic safety lens to maternal mortality reduction efforts. Dr. Noha mentioned my disclosures, and I have no real commercial disclosures. I'm hopeful to be able to shed some light on the National Academy Diagnostic Safety Framework, which has been discussed previously, talk a little bit about its applications to obstetric care, describe a simulation-based research effort to really unearth or characterize the role of diagnostic error in obstetric care. And then I want to prompt you to consider one key action that you can take in your own environment. And so at the end of the talk, there will be a QR code that contains all sorts of resources. So anytime you see a slide with this icon, there will be a resource in the QR code. I want to acknowledge that we are all intelligent and capable, and we want to improve. It really means so much to me to connect with this larger community of practice. And when it comes to talking about maternal morbidity and mortality, it's hard, it's sad, it's challenging. And for someone who, like me, who is an OBGYN and also a healthcare quality leader, it keeps me up at night. And if you go to the World Health Organization and look at the statistics from your area where you are, it's very, very clear that we can and we must do better. And what is shocking is that upon review, the majority of maternal deaths are preventable. More than 70% are preventable. And so this is a very important fact to consider. Well, there's much to be done. And if we think about it, there are so many efforts that are ongoing to address maternal morbidity and mortality. Some have worked better than others. And yet the numbers continue to rise or remain at unacceptable levels. And so, as has elegantly been stated throughout the meeting today, right, we think about diagnostic safety as that accurate and timely explanation of a health problem, or the ability to communicate that problem. And certainly when it comes to maternal care, we're talking about a birthing person as well as their support, their family. So there are many people to consider. And as Dr. Schiff so elegantly stated, all of us in this virtual room can probably talk about a diagnostic error that we ourselves have experienced or that one of our loved ones has experienced. And as he highlighted from his work, not only does this result in harm, but also tremendous cost in the form of malpractice claims. And so, diagnostic error in obstetrics is really understudied. It is a very nascent field. There are a few small studies, one in the Philippines, where diagnostic errors were 3 times more likely to cause complications. A few other small studies where they looked at events that had occurred, and a large portion of them either had a delay in diagnosis or a delay in treatment. So there's something here. Most maternal deaths are preventable. Lots of studies outside of OBGYN to suggest that diagnostic safety and error is a very large deal. And then also very crucial to think about the fact that clearly, we can and we must do better. So let's go back to, as I said, most deaths are preventable. So let's use maternal hemorrhage as an example. It's a leading cause of death worldwide, and most are preventable. And there is a clear definition, a cumulative blood loss, either after vaginal delivery or C-section. When it comes to taking care of patients who have hemorrhage, and again, I'm just using this as an example that is applicable to all sorts of OB care. To address a maternal hemorrhage, it requires a team of people. There is often uncertainty that plays out over time, and it requires tremendous communication between multiple team members as well as with the patient and their support. And so just as a reminder, there is a very clear scripted diagnostic process for maternal hemorrhage. In fact, you can find many checklists, many tools that go over the key steps from clinical history, from physical exam, and diagnosis. And yet, in so many cases, people suffer, right? There's a clear process, and yet people suffer. And so we really need to understand the interplay of that work system. And Dr. Schiff and others gave us tips on how to improve that work system, and what is traditionally a pretty scripted diagnostic process. And I just wanted to highlight how clearly steps, there can be breakdowns at every step of the clinical diagnosis, whether from underappreciation of symptoms that are reported, such as tiredness or thirst, physical exam findings that are not seen in real time, secondary to the sometimes challenge in examination. There is a delay in diagnosis due to, not quantifying the blood loss, but rather using visual estimation, and then a delay in responses. So again, at each step of this diagnostic process, there can be a breakdown. Recognizing that there is something here, right? There is something that needs to be considered. A few collaborators and I published last year an AHRQ issue brief on the state of the science of the contribution of diagnostic error to maternal morbidity and mortality. And here are a few key things that we found. And again, some of these have been elegantly highlighted in other talks, but clearly there is much to be done when it comes to applying what has been learned and appreciated and improved in other areas of medicine to OBGYN. So the first is to partner with community organizations to support the implementation, to facilitate person-centered communication, evaluate strategies to identify and mitigate bias, standardize risk assessment, and then clearly link those risk assessments to expected clinical interventions, develop standardized approaches to education and to simulation. We know that simulation can have a very powerful effect on obstetric care. What is the dosing? What is the frequency? How, what are the types of simulations that are most effective? And then, as Dr. Schiff mentioned, sort of the IT solutions. What is the health records contribution to obstetric diagnostic error? These are clearly understudied areas. So in an attempt to characterize the nature of diagnostic error in maternal hemorrhage care, through some work with the National Academy of Medicine and the Diagnostic Excellence Scholars Program, we embarked upon the following. The first was to develop an observation tool so that we could, look at simulated hemorrhage events that were occurring and characterize that error, right? This is very different than going into the chart after a hemorrhage has occurred, right, and looking at what happened. This is in the moment looking at errors. We then applied that tool to characterize the diagnostic errors that occurred. I'm going to share some findings with you. And then now we're on the journey of working to develop simulations and other trainings based on what we learned. And so just, to spotlight that my health system spans all 5 boroughs of New York City, and the simulations took place across all of the facilities within our health system. And so we wanted to develop an observation tool to capture the contribution of diagnostic error during simulated hemorrhage and actual hemorrhage events. And rather than recreating the wheel, again, while diagnostic safety is new in the lexicon of OBGYNs, as has been demonstrated over and over again today, there's so many tools that are available. So we took the SAFER DX instrument, which really provides guidance on how an observer can cognitively deconstruct the process. We married it with the Alliance for Innovation in Maternal Care debriefing form, which really outlines the key steps for maternal hemorrhage and also organizes them according to the 5 R's: readiness, recognition, response, reporting, and respectful care. We also wanted to highlight patient-centered communication. And so from the Society for Improvement in Diagnosis and Medicine, we utilize the Patient's Toolkit, which really sort of empowers patients to discuss diagnosis with their care teams. And then last but not least, we looked at the California Maternal Quality Care Collaborative, which also includes an evidence-based checklist. I encourage all of you who are working on maternal mortality reduction efforts to look at these tools because they really are well designed and help provide sort of a roadmap for the diagnostic process in OBGYN. We then began to link the instruments, taking the key actions and linking them to elements of the SAFER DX framework. We then applied a modified Delphi approach and using iterative feedback with experts, kept modifying the tool and then revised the tool during simulations as well. And so we were able to make some significant changes in structure, utility, and content. And here's what we came up with. The first page was really sort of instructions on how to use the tool. And this idea of met and not met was really important to the experts, and recognizing that met and not met would be a local definition. And so here we have the tool with the critical actions, met or not met, the observations of what were happening in real time, and equally important, the participants' reflections during the debriefings, right? Oftentimes we do something during an emergency, and only afterwards do we think about, well, why did we do it that way? And so we used a standardized scenario of a 39-year-old who had had 4 prior infants, BMI of 40. She had recently delivered a 4,000-gram baby, and this is an example of one of the simulations. And she begins to feel wetness between her legs, and so, sort of a hemorrhage unfolds. And so, we ran teams through these simulations, and then we observed what were the critical actions. And we used a very robust framework theory process to really answer the question, what is the contribution of diagnostic error to maternal hemorrhage care? Right? Again, this interplay of the work system and how did it either support or not support what was going on during the diagnostic process. So here's a screenshot of all of the key diagnostic elements. And then the coders who were analyzing this data really looked to see, well, what component or components of the work system either led to the item being met or not met. And, as you can see through this distribution of color, there are times where the same diagnostic element is either supported or not supported by a different work system element, really highlighting how important it is to address not just people's knowledge, but sort of the work system and the culture as a whole. And so let me give you an example. So here's a situation where a hemorrhage cart or a pack that includes all the tools that are required to address a hemorrhage was not met. 3 different instances. In one case, the team member actually left the cart in the hallway. It existed on the unit, but they just left it in the hallway and didn't use it. There was one instance where there actually was no hemorrhage cart at the facility. It was not part of their protocol. And in the third situation, the hemorrhage occurred in a little bit of an unusual setting, the postpartum unit, and there was no hemorrhage cart on that particular unit. So all of a sudden you can see here, if I was looking at a chart a week later, I would never really get to the root causes as to why this key critical step was missed, right? It definitely wouldn't be in the medical record. And so what's very fascinating is that, when it comes to the contribution met or not met, we really began to understand, team members were very generous in saying, what, when we communicate with patients, it's because we assign someone to support that person. On the converse, teams said, we were fixated on the tasks, and as a result, we didn't communicate. There's a relatively new agent. It's not new in medicine, but it's new to OBGYN and the treatment of hemorrhage, called TXA. And oftentimes, people said, well, I only remember TXA when I think of it with other medications that I know I give all the time. And other people said, well, it's new. I haven't made it part of my routine. All of a sudden now we begin to see very tailored interventions that we can make to begin to address diagnostic safety long before there is a maternal morbidity, severe maternal morbidity, or a maternal death. So our next steps are to continue observations in different settings. We're developing graphics that clearly depict the diagnostic process, or taking some of these bulky checklists and sort of mapping it across the diagnostic framework. We want to use the salient findings as mentioned to design and develop a self-guided simulation. We hope to establish a set of diagnostic safety related measures for various obstetric emergencies. We think this is going to be really important in really beginning to characterize the nature of errors at scale. And then we will be developing a diagnostic safety excellence toolkit for maternal mortality reduction. So what are some strategies that you can apply in your own environments? The first is to review key diagnostic safety resources. So many of them were highlighted today. And so I really encourage you to look at the AHRQ. I encourage you to look at the Institute for Healthcare Improvement, and also the Society to Improve Diagnosis in Medicine. I also encourage you to check out the AIM patient safety bundles, as I mentioned. The second is to engage local quality and safety stakeholders with diagnostic safety opportunities. And I also want to highlight a relatively new resource called Measure DX, which outlines several key steps for individuals to think about, sort of identifying, analyzing, and learning from diagnostic safety. And in this resource, and I won't go over every detail because I see that Dr. Noha is here, but I highlight that, there is a reason, right, that there are ways to engage each level of your organization, from board of trustees to clinical educators, in the diagnostic process. And there is something for everyone. And this resource very nicely outlines that. The second component of the resource is an organizational self-assessment, which really prompts teams to think about, various components of, sort of preparedness for the diagnostic safety analysis. And you can see some of those buckets here. I also want to mention that, diagnostic safety, as someone who in residency never learned about diagnostic safety, who only when I became a chief quality officer really began to think about diagnostic safety more deeply, I really encourage you to develop that capacity for diagnostic safety work. I also encourage you to really think about your diagnostic safety measurement strategy. And again, this is highlighted in this Measurement DX resources. Look at data that's already collected, some of which is listed here. Solicit reports from clinicians and staff. A lot of organizations will have some mechanism of collecting feedback from staff. Leverage patient-reported data, and I love to see that the co-production with patients is really, really crucial. And then last but not least, the EHR, as was mentioned, right? You sort of think about all those patients who were referred somewhere and then never made it, right? They were a pregnant person was referred to cardiology and never made it, right? That you're enriching your population to look at how diagnostic safety and diagnostic error may contribute to these downstream horrific, tragic cases. And then the last is, really co-create a process to analyze events. And again, the Measure DX resource highlights sort of a basic process. And I think the PRIDE framework and others are a really lovely way of thinking about, diagnostic safety events, because we can't look at everything, right? And so how are we going to enrich what we are looking at? How do we create the psychological safety to look at those cases and create that feedback loop is really, really crucial. So I invite you either in the discussion forum chat or text it to yourself, email it to yourself. What is one concrete action that you can take in your own environments to begin to apply a diagnostic safety lens to maternal mortality reduction efforts? I and my other colleagues are firmly convinced that we can and we must do better. And diagnostic safety, applying a diagnostic safety lens to maternal mortality reduction is one important way of doing that. I thank you, and I look forward to engaging with anyone who's interested, either on Twitter or LinkedIn. We're all in this together. Thank you very much.
Thank you so much, Dr. Kumal, for a very nice subject that you covered very well. And thank you for inspiring us that we can really make the difference and eliminate the diagnostic errors. I have already added you on LinkedIn, so please accept my invite. So next, we have Dr. Ahmed Al-Wazzan. Dr. Ahmed is Deputy Director of the Medical and Clinical Affairs of the Royal Clinics of the Custodian of the Two Holy Mosques in Riyadh. Dr. Al-Wazzan is a very highly achieving leader and a lifelong learner. He is looking for new challenges and thrive on success. He's full of ideation that he likes to execute and responsible with significant activation to himself and others. He says about himself that he's a team player, so he appreciates the teamwork and team dynamics, who collaborate with his team to achieve all their goals and beyond in the most efficient manner. So please welcome Dr. Ahmed Al-Wazdan. Dr. Ahmed, the mic is yours.
Thank you, Dr. Anna, and I hope the audience would enjoy the coming talk about diagnostics and emergency department. So I'll just share my screen. Okay. Okay. I think it's evident, right? You see my screen, Dr. Anna?
Yes, it's Dr.
Okay, Bismillah wa salatu wassalam ala Rasulillah. So one day I was sitting in my
There's a
department.
small window in your screen. You can close it.
Sorry?
A small window in your screen.
Come again.
Okay, you can start after it.
Sorry, is it running well? Excuse me. Do you hear me? Okay. Okay, sure. Okay. So one day I was sitting in my department and in a resuscitation bay. That's not actually my department, yet I got the picture from the net. And we had a trauma patient, and we had one of our dear colleagues, a nurse. I hope these ladies are all pregnant and they're doing emergency services. And that patient needed to do an X-ray as a trauma patient. And she was sort of hiding, and she left the area technically. And although she knows that it's not so harmful after 3 or so meters, yet she was concerned about her baby. That was on one incident. The other day, I've seen, again, an intubated patient in my department where we had to do an X-ray in that curtain. And next door, or next curtain, actually, there was a mom with her son who was sick, but that lady was pregnant. And the X-ray tech took the X-ray without letting the other lady that I'm doing an X-ray. So I would say that there is a radiation injury that happened, or a radiation exposure that happened at that incident. This makes me think all the time, what are we doing in the emergency department from the perspective of a radiological perspective mainly. And this talk will apply to all diagnostic procedures that we're doing in the department. Now, if you look at the X-ray film, when I Google the X-ray film, it showed me the X-ray actual films, and which is not available so much, at least in the central cities. Yet you could see this is the end result where you see it. It's just a photo or a picture on the PAC system. However, if we divide them, how you reach to that X-ray or to that diagnostic procedure, you have specific things in the emergency department that goes with the structure, with the process, and the outcomes. I wanted to stratify my presentation into that, so that for the audience, if you want to remember the patient safety issues, remember them in that sequence, so that it might help you working on them. So let's start with the structure. So if all of us, if you go to the inpatient floor, the floor is well known, like 1, 2 beds, 4 beds rooms. The bathroom is in a certain area. The flow is very clear. So you go from one side to the other side. However, the emergency department, this is an example of an emergency department. And this is what's unique about emergency department is usually they are complex design. Some emergency department have, for example, X-ray machines, portables. Some of them have X-ray rooms. Some of them have CT scans, etc., etc. And the areas of the department is quite unique and different. So that's the first thing that might affect your diagnostic safety in the emergency department, which is the complexity of the emergency design. The location identification. So many people would work with, the admission ward would be Ward 5, bed number 5, for example. But in the emergency department, there are a large number of beds, especially if you are a hospital where you admit in the hallway or you take care of patients in the corridor. Areas like triage, where many times we start investigation, like withdrawing blood or doing X-ray, and the patient's in the triage, so you cannot locate that patient. Many times, you could just see the label in the system. If you are doing an electronic system or a paper-based system, you would see a note that this patient is in the triage. However, he might not be physically there. Patients are moving in the emergency department from an intermediate care to a minimum care or to a critical care area. So the location identification is a major issue in the structure of the emergency department. Rooms versus cubicles. We know that X-ray, for example, does not cross the cement walls. However, curtains are not protective against X-rays. And many emergency departments are still using curtains as a divider between emergency patients, which is a major concern. And I'm talking about only radiation here. Yet you can name it, patient confidentiality, cross, reactivity or missed identification, etc. So again, these are players in the safety, and I'm putting this so generic so that all the audience would go back to their emergency department, look into these factors, and think, am I really exposed to that risk or not? Access and hallways, the emergency department, many times you have walk-in access, you have ambulance access, you have the registration, you have access from within the hospital. Some hospitals where they serve helipads, again, that's another access. So the access itself and the hallways is a major issue in the emergency department, where many departments use these are patient care areas. The distances. Now, if I have a patient who is doing an X-ray, and many of the new emergency department have an X-ray and a CT scan within the department, it's different than if I have the X-ray 50 meters away from my department, or in the second floor, or in the 9th floor. I remember working in a trauma system where the X-ray is, the CT scan is on the 9th floor. In the same city, the CT scan was literally 2 meters away from the trauma base. So these things are points to consider with the distance. If I have a system like a vacuum system that delivers samples or so, that's another thing to consider. Now, this is from a structure point of view. Now, talking about the processes in the emergency department is quite interesting, because emergency department procedures are quite unique and special, or there are certain special areas about them. The time pressure. Everyone in the emergency department is in a hurry. This is a well-known. Everyone wants to be seen fast. Everyone wants to be done with fast, and this per se will apply pressure on the staff, on the technicians, on the patients, and on everyone. So this is a problem that we are facing every day and every night. Unplanned studies. So in the outpatient clinic, or in the medical floor or surgical floor, usually studies or blood work are all planned. There are orders ahead of the time. There are planned studies to be done ahead of the time. But in the emergency department, this never happens. Patient flow dynamics. So it's worldwide known that the early morning hours are busy times. Afternoon is a busy time. Like today, nowadays, we're having the World Cup. So after football matches is a busy time. So there are certain patient flow dynamics are important. The actual patient flow within the department is important, because some departments do the registration first. Some of them, they do visual triage. Some of them, they triage first, then they do the registration. So many things are controlling that safety. The unique elements of the patient care, which is the some procedures that we do in the emergency department, which are physician at the triage that you don't see usually in the outpatient clinic or in the ward. We do sometimes keep vertical patients vertical. There are certain things that we do in the emergency department that are unique, and out of these a certain patient safety concerns can be generated. Repeated studies is a very important thing. Many times, especially when you have a patient who's coming for a second opinion, who does not declare previous studies, whether X-rays or even blood tests, they don't declare it because they want to test you. They want to make sure that they're taking the maximum out of it. That's one thing. Non-availability of the medical report of that particular patient is something that might repeat itself. Special population is a major concern. It's the emergency department. You might end up by delivering a lady, taking care of the neonate who just was born, and in a few minutes you might take care of a patient who has cancer and he's 100 years old. So all of these factors in the process of the emergency department are areas of concern and patient safety that frontliners and quality team and patient safety officers should consider and have a close look on them. Respiratory illness, COVID came in, and before COVID we have the SARS outbreak in Saudi. Since then, we have the respiratory illnesses affecting our triage and affecting our processes in the emergency department. Now, if we talk about radiological outcomes, I chose radiological outcomes because they're quite unique, because the choice of study is very challenging in the emergency department. You don't have a time to decide. Sometimes you don't have the opportunity to decide. The patient might not give you enough time. The available resources is not always there. You don't have MRI around the clock, for example, yet you have to do a decision at that time. So this is something that will affect the patient safety. The quality of study, when you have a trauma patient where you do a bedside portable X-ray, is definitely different from doing an X-ray on a regular person who's standing and taking a full breath for a chest X-ray. So the quality of study is something that affects the outcome of these procedures in the department. The time of the study also, when we do ultrasounds, for example, or we do blood tests, we ask the patient to be fasting and for the last few hours, etc. This luxury is not there in the emergency department. So this is another factor of patient safety, of how would you interpret the reports that are coming. The study indication, again, sometimes are not clear. Sometimes you're faced with an unconscious patients where you do CT scan, you do CBC, electrolytes, sometimes you shoot in the dark, and that does happen. So this is another thing that will affect the outcome of the patient and his patient and the patient safety. The reporting is always an issue. There are always initial reports for the emergency team, and there is always a final report done by consultants or senior staff, and there is always changing findings. I am personally one of those who had one of my son, who had a finding, and he went to surgery, and next day the finding was changed, and it was normal finding, although my son went to surgery. So this is a problem with the reporting in the emergency department, and it affects the outcomes and directly affects the patient safety. Now, I'll just focus on some areas of concerns. The radiation exposure, I have talked previously about it. In my shift, no portable X-rays apart from an intubated patient or sometimes a trauma patient. People sometimes use too much of portable X-ray for their own convenience, which is not appropriate. We have staff, we have families, we have other patients who are in the area who really, if you look in the emergency department, and any of you who've been to the emergency department as a patient or a visitor, you would see that people sometimes they shoot X-rays, without paying attention to the other people around. The type of study as well is important. You need to not to over-radiate people and to choose wisely. Repeated studies, as we have said, you might have a patient who had a study just now in another hospital who comes in, especially when we're talking about CT scan and major studies. Special population who would be of a concern or not easy to deal with, the critically ill patients who are there all the time. The choice of study, the way we do it, the location of the study is very important. So this is another factor that will affect the patient safety. Pediatrics, many times pediatrics are not cooperative, they cry, they're in pain, they're scared of the place. And we try sometimes to sedate them to make sure that they have the appropriate X-ray or the appropriate study or blood work, etc. But these are people that we need to keep an eye on or to be careful with to do that. Pregnant ladies is another population that we need to be careful with the radiation, with the being in the emergency department is a concern. Trauma patient is one of the riskiest patients because usually they're young, they're borderline, especially if they're critically ill and if they're being sent outside your emergency department. Most of the time, you will hear a bad news sometimes happen if you are not so much ready. And that's why usually sick trauma patients, they don't get to send to CT scan, especially like in my hospital. It's like a 10 minutes walk from the emergency department, and especially at 3 a.m. where no one is there. The last thing you want to hear is a code blue in the CT scan. And this applies also to sedated patients, especially a common example where you do a shoulder dislocation, you do a procedure sedation, and the patient gets asleep after that, and you send them to do an X-ray post-reduction, which I teach my resident, it's not very much indicated, but you send them to a place where nobody's there, suddenly you have a code blue in that area. So this is another area you need to be careful with. Now, the study location is a very important thing. You need to choose between portable studies and within the emergency department or remote locations in the hospital. I urge you all that if you have your CT scan, MRI, or just a simple X-ray or ultrasound in a far location in the hospital, in addition to the slide I mentioned before, which are the people or the special population, I think you really need to think twice before sending your patient there, or you might take the chance, but you send a senior physician with him, whether your senior resident or somebody who's reliable to take care of him. It's not uncommon to have a patient who deteriorates in the CT scan. This is not uncommon, it's very common. So you need to be very careful with these things when you're doing it. The last thing would be the patient issues. Patient identification in the emergency department is a very frequent issues. Don't Joe always happens. Unknown patients always happen, whom they get to be known after a while, which is, the cardiac arrest, motor vehicle accident. They come as an unknown patient, then eventually they get identified, and this is the gap where patient identification problem happens because the sample were sent by a certain name, and eventually the result will be labeled to another patient, especially if you need blood transfusion or so. Sometimes a major disaster happens when in the emergency department in particular, they identify patient by the bed number, which is a big no. In the floor, again, it's a big no, yet you will have the same patient on the same bed mostly for more than a day, so it will be known. But in the emergency department, the turnover rate of the bed would be very high. This is something that you need to know. The patient transfer is an issue where actually the actual physical transfer from the bed to the CT scan table, to the other stretcher, to the X-ray is a major thing that you have to really be careful with. The cooperation of the patients. This is something else that might bring you patient safety concerns. Many patients are delusional. They are, elderlies or intoxicated, or they're pediatric. They don't cooperate. And per se, no cooperation of patients might give you lots of patient concerns that you have to be aware and careful with. Patients with pain or in pain is another patient safety concern. Usually I teach my resident, no patient should be in pain in the department if his pain is so severe so that his respiratory depression will happen after you give the opioids, then this patient needs general anesthesia or intubation. So these patients, don't expect them to be cooperative when you are doing the radiological studies, etc. External studies are an important thing because many times we receive patients who are coming with CT scans or with X-rays or lab report that are coming from outside, and you have to interpret, or you're expected to interpret them or to incorporate them into your medical care. And this is another major safety concern that you have to be aware of. And you put your plans how to deal with these concerns. The disclosure of the recent studies, as I have mentioned earlier, many patients would come trying to test us, the frontline people in the emergency department, whether we would know or not, and that's a major challenge that we do. The reporting issues, the fast bedside ultrasound is a big example of a failure to report, because usually these are bedside X-rays or ultrasound that are not in many hospitals that are not in the system, and that's a major thing. Critical results reporting is another thing. Many hospitals forget the emergency department as a place where they need to report critical results, whether be it radiological results or blood results or CSF results. So they forget about the emergency department and they need to report it. And the emergency department forget how to convey the message to the patient, whether they are admitted or they were discharged home. So this is another issue with the reporting issue. Initial versus final report, like the story that I told you about my son. Initial report was an indication of surgery. My son had the surgery and it was normal. The final report came as a normal finding, so he should have not gone to the surgery, and that's a major issue. The hospitals need to control that and govern that very well. Reports, changes tracking, this is another thing. The report might not completely discard the first one, yet it might build on it, and all of that has to be tracked. Unfortunately, in many hospitals that I worked at, it does not track who changed what and at what time. So the medical legal aspect and the patient safety is very well compromised over there. What I have done in this presentation is I have dissected the emergency department into structure, process, and outcome. I have identified certain areas of patient safety concerns in these three domains. And also I have highlighted certain areas of weaknesses or vulnerability in certain areas. I will leave it for you all, the audience, to go back to your emergency department. I'm sure all of you are leaders and patient safety advocates. So you go back to your departments, go through this list and double check again. Would you have an active patient safety concern in that area? Thank you for inviting me, and back to you, Dr. Hassan.
Thank you so much, Dr. Ahmed, for highlighting the risk areas and diagnostic errors where it can happen in the AR department. It's one of the highest risk areas, and who didn't visit the AR department earlier. So thank you so much for all the work and the hard effort you're doing and for the wonderful presentation. Next, we have Sofia Macedo. Sofia is the clinical leads director at the Center for National Health Insurance in alignment with the Health Sector Transformation Program in Riyadh, Saudi Arabia. She is having a degree in Science of Nursing from Portugal. Sofia carries 17 years of international and national clinical practice and 14 years of experience within the Saudi healthcare system. Sofia has completed her Master in Evidence-Based Healthcare from the University College of London, United Kingdom, and she is a certified professional for patient safety by the National Patient Safety Foundation. She holds expertise in clinical education, clinical research, quality, evidence-based healthcare, magnet fundamentals, patient safety, global health delivery, and healthcare system strategic purchasing. Sofia is one of the contributing authors to the International Pressure Injuries Prevention and Treatment Clinical Practice Guidelines that's released 2019, and she co-leads the national service standards setting for current and future health systems in Saudi Arabia. In the past, Sofia was responsible for planning and curriculum development of the patient safety at national level, contributing to the development of patient safety officers Saudi National Workshop. Most recently, with her leadership role, she has co-authored the most recent regulatory paper on staffing safety levels, on safe staffing safety level. Within Sofia's most recent role, she advocates for and co-leads the implementation of patient-reported outcome measures nationally, which has led her to take part of the first Saudi national cohort on value-based healthcare implementation, and is currently designing the CNHI quality assurance framework by a national strategic purchaser while supporting the design of clinical requirements that will ensure national clusters' readiness to deliver value-based healthcare. So please welcome Ms. Sophia. Sophia, the mic is yours.
Thank you, Dr. Nuha, for the lovely introduction. I'd like to say also thank you for the opportunity, and it's an honor as a former employee of the Saudi Patient Safety Center to actually taken part of this event, but from the other side. And I really would like to share my appreciation to my former colleagues. So I'm going to share now my screen, and I do hope you can see it. I guess it's fine? Yes, perfect. So what I'm going to try to do within the next 25 minutes is to really show you how a national, let's say payer, I know I have strategic purchaser, but let's call it payer to make it easier, how a national payer of healthcare can really leverage the safety of care and specifically the diagnostic safety in Saudi. I know I will probably be reinforcing ideas that were already shared throughout the day, especially in the morning with our colleagues from Health Holding Company, Dr. Faisal. However, there is never over communication. So I really hope by the end of my session, you really have that understanding that as a payer, how can we support and leverage safety? So we know that the Kingdom of Saudi Arabia is really undergoing what's probably the most ambitious and wide-ranging healthcare reform program in comparison to any country in the world. So this picture really shows you just that in the past, the Ministry of Health used to hold three roles as a regulator, as a provider, and as a payer. Now, why is that we needed to change? So over the past decades, the country has made very significant advances in terms of accessing and the quality of healthcare. So today in Saudi, there are more doctors and more hospital beds per capita than before. And as we know, an average life expectancy has risen sharply from 62 to 75 years, including dramatic reductions, thankfully, in infant mortality. There are advances, obviously, that we should be rightfully proud. Now, at the same time, the kingdom does face many of the same healthcare challenges that other high-income countries are facing around the world, and these are very well known, right? So a growing, aging, and more sedentary population has led to increasing numbers of chronic conditions and steeply rising healthcare costs. And notwithstanding the progress of recent decades, wide variation still persists in access to care and in the cost and the quality of care provided. And those of us that have been in Saudi for long and those that live in Saudi, we are very and fully aware of those discrepancies within the territory of Saudi in terms of access and quality of care. So what is it that we're trying to do? So accompanying and enabling the healthcare transformation in care delivery, one of the biggest changes that people will see or are seeing already is a separation of healthcare provision to purchasing and regulation. And at the heart of this effort is the decision to establish a national strategic purchaser. Now, for the sake of the presentation, I'm just going to call it a national payer, even though there are considerable differences between strategic purchaser and payers. But just for the sake of the presentation, I'll just call it that. So, and the national payer of Saudi Arabia is the Center for National Health Insurance that is committed to deliver value-based healthcare. And this is what I'm going to try to show you how this new way of paying for care really leverages and supports the agenda for safety. So the model you see in your screen, it's a model developed by the Center of Value in Health. And basically, by utilizing this approach, what we will see is a health system that will focus more on delivering optimized health outcomes through the fair and the efficient allocation of the available resources. Delivering this will require a focus by the healthcare providers on population health, which, by investing in preventative and coordinated care instead of merely treating those that are already sick, will allow them to improve outcomes at lower costs. In this shift from just paying for services to value-based healthcare, CNHI, the Center for National Health Insurance, is responsible for designing and implementing the payment models that ensure that the funding and incentives are in place to enable and encourage providers to focus on the outcomes that will matter the most, including access to care, safety, quality of care, cost of care, and obviously the health outcomes overall. So in this regard, what happens? So CNHI has been established by the ministerial decree as the only national body covering citizen healthcare costs in line with international best practice, creating a clear distinction among the caregiver, the regulator, and the payer. This will enable us, as in CNHI, to focus on paying based on the value provided, ensuring quality and safety of care, while continuing to provide free treatment for citizens, as opposite to paying for the volume of care that has been provided. Now, for us to achieve this, how can we ensure that we're really responding to the needs of the country? So there are three, we looked into some of the stakeholders' perspective, and what we found is, as a beneficiary, what do beneficiaries want really? They want to enjoy life without being ill and without their illness getting on the way of their life. They want to be able to look after themselves, and they also want to be treated as a person, not just as a disease, as we see it quite often, by the healthcare providers. And what do we want as clinicians, right? So what do we want? And as one of our colleagues put it earlier on her earlier assumptions, we are good people and we don't want to harm, save some exceptions. But overall, nobody wakes up in the morning wanting to harm anybody. So what do we want? We want to deliver the best quality of care possible and to improve the clinical outcomes. We want a job that stimulates interests and rewards us, obviously. And obviously, we want also a health work-life balance. And this would drive us to talk about the workforce safety, which we've done some work around, but we'll leave it for the purpose of the presentation. And the national strategic purchaser, so us, CNHI, what do we want? We want to be able to demonstrate value for the money that is going to be invested in healthcare. We want to minimize financial and clinical risk for our patients. And we want definitely to ensure that the healthcare that we're going to pay for, it is safe and it's effective care delivered to all our beneficiaries. So in this regard, the CNHI's payment strategy is going to be grounded in a set of guiding principles that it's obviously aligned with the Health Sector Transformation Program Healthcare Value Framework. So, and basically those principles, there are three principles, and they will then be somehow subdivided in other subcategories. I'm going to go very quickly. So the main three principles are value for money. This means that budgets should be sufficient to enable the delivery of health benefits and any additional requirements that is safe at an efficient cost of care. Also, we'll be obviously looking into value for many people, so it takes us to the equal access and cover of the population. And in this regard, what's important for us as CNHI is that the outcome KPIs will be designed in a way to incentivize a balanced focus on all facets of value linked to key transformation objectives, including the access, quality of care, efficiency, equity, and population health. Now, as a strategic purchaser for the kingdom, CNHI will have 3 levers with 12 underlying requirements to deliver safe care. Now, from the 12 underlying requirements, I just selected the ones that are related to the safe provision of care. And here we can see that the requirement number 3, it's regarding the focus on outcomes delivered for a given budget, is a central insight underpinning the shift to value-based care, ensuring that those outcomes are clearly defined and communicated and remain linked to overall system objectives. It's critical for us at CNHI. Number 4, or the requirement that it's as number 4, the CNHI will need to provide input into the national model of care based on its own research into high-value delivery models underpinning international benchmarks. So likewise, it will recommend functional capability requirements to be included in the provider's contracts. Furthermore, the CNHI contract will be the vehicle for communicating the outputs and the outcomes that providers are expected to deliver in return for a given budget or price. So as you can imagine, by including safe care principles within those contracts will definitely drive the journey to a safer healthcare provision. CNHI core role will be to decide what payment models to deploy in purchasing different services in order to establish the right incentives to deliver safer care. And then we have number 10, CNHI purchases publicly funded healthcare service on behalf of the citizens, residents, and visitors to Saudi, and is responsible for the overall health system budget. And as such, it is critical for us that we establish performance transparency. And this is probably something that will be quite new, and that we're going to have to be very open-minded to do so. And then towards the last, the core objective of value-based healthcare is to optimize the health outcomes for a given budget. And last but not the least, designing and managing provider failure regime in case we do see any deficits from a financial and obviously from a clinical side, which this will mean, for instance, if there is a provider with high occurrences of unsafe events, CNHI will have in place, in collaboration with the regulator, a failure regime to manage those incidents. So in that regard, CNHI vision and strategic objectives have been defined in line with CNHI key roles, as well as crucial function in accelerating the system's transformation towards safer healthcare. Sorry, I just did something here. Okay, so what is it that we're really trying to do? So as you can see here, very simple, is the formula that I'm sure you've been seeing. That what is value? Value, it's the quality over cost. Now, what does this mean exactly? So healthcare organizations in Saudi, providers and payers, are simultaneously preparing to transition to this new way of payment, which is a value-based healthcare. This new system has big advantages for patient safety, and specifically in diagnostic safety and patient satisfaction, and is rapidly replacing the traditional fee-for-service model that we've been seeing so far. Those old models were built around volume instead of quality of services. So instead of billing and accepting payments just because of what you provided, value-based healthcare instead will incentivize providers to focus on improving patient outcomes, which includes safety improvements. The value that we're talking here is based on comparing improved health outcomes to the cost of the patient care necessary to achieve those outcomes. So value-based healthcare provides incentives for healthcare providers to focus on patients' overall health by changing the way the care is delivered and the way payment is collected. So we did hear earlier on how high reliability organizations do focus on what did go wrong and how things can go wrong all the time. And so this model, the high reliability and continuous improvement that value-based payment system will require, mean that patient safety will always be a priority, because if you do have unsafe care quite often, this will show that there is no value for the investment being done, or the money is not being put in the right place, and therefore this by producing payments according to the value and to better outcomes, providers and hopefully leadership will see the need to shift into different way of doing things to really provide better healthcare. The outcomes that we'll be looking will be a twofold. So the clinical outcomes of a procedure or treatment or intervention, and the patient's perception or feeling following that procedure, treatment, or intervention. Now, for the sake of time, I'm not going to go through the whole slide, but when I try to put the unsafe care in numbers, as you can see here, the one that I would like to highlight is the one that says that diagnostic errors contribute to 10% of patients' death and 6 to 17% of hospital adverse events. Now, why is this important to bear in mind? Obviously, for us as CNHI, this is it's crucial, because we have our remit to deliver a value-based healthcare. But from a social impact and economic impact of unsafe diagnostics, how does this affect our country and our population? Now, this, I want just to highlight, this picture was developed for the time when we presented it at G20, and it really brought a lot of attention. And the reason why I've chosen to use it again is because it really shows how each country, including Saudi, loses twice every time a citizen suffers from unsafe diagnostic practice, be it by missing, delayed, or wrong diagnosis. So the harmed person, once they suffer a diagnostic error, will stop being considered a profit center, as he or she won't be able to contribute to the internal economic growth to Saudi, consequence of the disability, potential disability associated to the harm caused to him or her. And in addition, it will become a cost center, as this person will require prolonged treatment and care, becoming dependent on governmental support, and may not be able to join the workforce again. So he or she becomes a burden to the healthcare system and consequently to the overall economy of the country. If we collectively don't act on this, the economic forecast related to the burden of harm, it's unsustainable. So one other argument that I'd like to bring to the attention is, if we do a quick search on what were the top 10 patient safety concerns in healthcare before the pandemic, and what are the top post-pandemic 10 patient safety concerns, we'll see a difference. So by 2022, in addition to the most known and common patient safety concerns, the pandemic emerged new concerns, because the way healthcare system has changed with the pandemic, so the unsafe care has changed with it, and therefore other safety concerns have emerged. So in addition to staffing shortages, in addition to other like vaccine coverage gaps and errors, there are one or two in particular I'd like to highlight. So one, it's the concern around telemetry monitoring. And we know that in primary care, mainly, there was a lot of the appointments and consultations that started being conducted online. And with that, also the monitoring of patients started to be done remotely. And this can bring basically another area of concern and another area for more errors. And also, definitely, as you can see here, the cognitive biases and diagnostic error has emerged as the top 10 patient safety concerns post-pandemic. So in the past decades, quest to improve patient safety has chiefly addressed quantifiable problems like medication errors, healthcare-associated infections, and surgical complications. And as we've discussed already throughout the day, diagnostic error has received less attention, despite the fact that landmark patient safety studies have consistently found that diagnostic error is common. In the Harvard Medical Practice study, diagnostic error accounted for 17% of preventable errors in hospitalized patients. And a systematic review, curiously, done on autopsy studies covering 4 decades, found that approximately 9% of patients experienced a major diagnostic error that went undetected while the patient was alive. So diagnosis is one of the most important tasks performed by primary care providers, and diagnostic errors can lead to patient harm from wrong or delayed testing or treatment. And because of this, they have emerged as a global priority in patient safety. Now, if we look into the price, so diagnostic errors and other inefficiencies, in this case into the US economy, may cost around $750 billion each year, which is around 30% of the annual healthcare allocation. Now, I just decided to do a very quick scenario that I'd like you to bear with me. This is very basic and just very simple. But I just decided to see, okay, so if we know that the amount of budget that has been allocated to the healthcare system in Saudi for the fiscal year of 41-42 Hijri calendar was around, let's say, approximately 80 million. If we consider that 30%, like in the US, that is being allocated to treat or to cover diagnostic errors, this will take us to an amount of approximately 24 million Saudi riyals that we will be paying for in diagnostic errors. As CNHI, this is a very big risk for us. And obviously, behind each number, behind each Saudi riyal, there is a person that has been harmed. So there is no single cause or single solution to the problem of diagnostic errors. And as we've seen earlier, the National Academy of Sciences has defined diagnostic error as, either the failure to establish an accurate and timely explanation of the patient's health problems, or communicate that explanation to the patient. So diagnosis often results from cognitive errors linked to knowledge gaps provided in experience with specific problems or biased human reasoning. Other results from failures in care coordination, communication, or reporting of test results, as our colleagues have mentioned before. So what is the CNHI? What is CNHI from a clinical perspective try to do to leverage or to protect patients from some of those errors? So CNHI is committed to establish transparency around efficient cost and quality of care through costing, coding, and performance data. So considering the pivot role that CNHI holds as a strategic purchaser of health services, CNHI has developed it's on the way, as it was mentioned earlier, developing the CNHI Health Quality Assurance Framework. And this framework becomes the guiding principle through which CNHI, which is situated outside of the daily quality production system, will operationalize the value framework through contract management with our health providers. So this assurance framework system provides transparent and independent confirmation to CNHI and its beneficiaries that quality and patient safety and all the components of governance are being implemented as intended, and the findings from these components being identified and acted on effectively. So what I try to do here is, when we look at potential causes of diagnostic error, and this has been already discussed from some of our colleagues, and if we look into possible contributing issues to those factors, I'd just like to highlight that CNHI has an approach to try to mitigate each one of them. So if the issue access due to lack of money, remoteness, literacy, travel constraints, so CNHI needs to ensure access to all beneficiaries to a single unified national benefits package of care, that it's subject to the same quality indicators, that if there is lack of sufficient competent healthcare professionals, CNHI budget allocation is to ensure that the providers have enough funds to cover for high-level healthcare professionals. CNHI will also leverage the promotion of integration of care at micro, meso, and macro level, which will, on the other hand, promote teamwork, which has been already discussed as an issue that can promote diagnostic errors. CNHI also will be promoting the model of care pathways that reflect best evidence in diagnostic tests required through the service specifications that we develop. The data reporting based on high quality and clinical documentation and coding. So this will also be a standard for CNHI, and therefore will probably have better thought process when assigning a diagnosis to the patient. As mentioned, we will be promoting integration of care vertically and horizontally, hopefully closing the gap between missed referrals. The payment model will be based on electronic data sharing between CNHI and healthcare providers, which will promote the budget allocation for health digitalization, and as well as a payment model that is based on value-based health requires the collection of most matter to patients. So the assurance of clinical quality and therefore safe diagnostics will be reflected in the contracts, as you can see here. That will be established between the CNHI and the CNHI providers in alignment with CNHI clinical assurance requirements. These requirements, which are embedded in the contracts, will serve as a set of clinical targets and outcomes agreed between both parties. So in a broader context, CNHI providers shall expect to embrace the new emerging paradigm of healthcare delivery that includes improvement of population health, improvement of experience of care, and this is where the assurance of safe care lays, and reduction of capita cost of care. Now, definitely because of this, CNHI is a proactive payer and it participates in expanding quality transparency and lower costs is crucial to improve patient safety and reduce unnecessary spending or waste, as some authors like to call it. So CNHI becomes therefore a vital catalyst to ensure the quality and consistency of health services, reflective in a safer performance and accountability of health organizations towards the population they serve. Yes? Sorry? Sure. I'm about to finish. So CNHI so these are some of the main strategies that we will be implementing when contracting with healthcare providers that ensure safety of care. So clinical quality is met through the contract targets that reflect the provider's application of methodologies and tools driven by a holistic approach to quality management, as opposite to isolated methodologies that ensure quality in the horizon of systems' daily operations. Now, I just want to highlight that we, CNHI, we won't be telling how providers will develop their methodologies, or they will, they're free to choose whatever approach they would like to improve their safety of care. We will be there, but we will be, however, be looking for outcomes that do reflect safer care and specifically safer diagnostics. So measuring the quality of the services being provided allows CNHI to detect variations in the provision of care of a given service at local and national level. And this is an important activity as variations in healthcare are a source of inefficiency, unsafe, poor quality of care, and waste. So with this last slide, I end my presentation. So CNHI ensures that health teams that deliver care are safe, effective, efficient, and patient-centered, timely, and equitable, and holds providers accountable for both quality and cost of care. And value of savings is achieved as CNHI identifies potential inefficiencies and supports diagnostic-related KPI implementation. The Saudi providers contributing, therefore, to excellence and reduction of variation across providers of care. So thank you so much for your attention. And
Thank you so
I'm
much.
happy to take any questions at the end.
Thank you so much for highlighting the link between diagnostic errors and the value-based healthcare and the current era in Saudi Arabia that's really going toward value of healthcare. I think you covered the topic in a very interesting way. So thank you so much. We'll keep the questions up to the end. So please be with us. Our last but not least speaker is Ms. Nada Al-Harbi. Ms. Nada is the Director of Quality Management Department at King Faisal Specialist Hospital Research Center. She's an intellectual life learner. She's holding a master's degree in public health, health systems, quality management, and various professional certificates. She likes to help to improve their organizations, to improve their performance, efficiency, and increase overall reliability by providing in-depth assessment and analysis on organizational factors and culture. She possesses an exceptional skills in improving team performance and influencing change. She's wise and value-driven professional, leading by influence, achieving the goals by creating a mutual mental framework, and by developing others for best thinking to create consistent accountability and thoughtful delegation. She's very dynamic, motivated, with high emotional intelligence, great problem-solving skills, utilizing appreciative inquiry and communication. Also, she has great abilities to create impacts through building capable, sustainable, and learning systems. She do much of policy development and review for many entities and regulatory bodies. Also, she's an initiator and optimizer leader. And I've been participating with Nada in many workshops. I can also assure that she's a wonderful speaker and a great presenter, and she's an advocate for patient safety and quality in Saudi Arabia. So welcome, Ms. Nada, please.
Thank you so much, Dr. Noha. And thank you so much, the Saudi Center of Patient Safety, for your tremendous and continuous support to the business case of patient safety. We cannot communicate enough. We cannot advocate enough. We've been talking about the business case of patient safety for the last 30 to 40 years, and yet we're not close to our goals. So let's continue this effort. Together, definitely we can make the change. Definitely we can make our industry much, much safer. Before I begin, I'd like to make a little correction to the introduction. I'm no longer the Director of Quality Management at KFSH Research Center. It will always still be my home to go to, but currently I'm pursuing a personal goal, which is my own business and consulting and training. Let me try to share my screen. My topic, the one assigned to me, is to communication for diagnostic errors.
Wish you all the best, Nada, in your new role, and you will shine wherever you go.
Thank you so much. Am I projecting? Am I sharing right now?
Not yet, Nada, not yet.
Please alert me if I am.
Yes, it's clear. You can start.
All right. So communication for diagnostic safety is actually one of my favorite. I always believed, and not only me, I know that many of the advocates in the field of patient safety, performance improvement, and overall of healthcare industry reliability believe so much in communication. The second part, which is around diagnostic safety, diagnostic error, was well covered by my colleagues. That we shed really good light today on the prevalence of the diagnostic errors, the areas where we need to focus more. But allow me to share what I had just prepared. And as Sophia mentioned, we have to emphasize on all the previous messages. This is how we can make change, So if we talk about the diagnosis process, it's as we all know, it's the foundation and the fundamental of the good clinical practice. It's an essential steps that help us all to achieve the optimal patient outcome. However, based on a recent released and study by the IOM, it was concluded that each one of us will experience at least one diagnostic error in our lifetime. Based on many of the studies that I came across and my practice for the last 7 to 8 years in patient safety, I think this number is conservative, and I think the number is way more than that. However, today we're talking more about it, and hopefully this can induct more research around the real prevalence of diagnostic errors, especially in the region. And there has been a few organizations that encouraged us as a healthcare industry to time and effort to focus on the research area of diagnostic errors. And I know that the Saudi Center of Patient Safety working really to establish a strong unit on research in the field of patient safety. So a few data just to share. 57% of all diagnostic failure happen in ambulatory care. 1 in 20 patients who attend a primary care appointment this year will experience diagnostic error. 79% of diagnostic errors are related to patient clinical encounter, and this is the main focus of my short talk today, is how communication can fail, and by knowing how, we probably will know how to fix it. The challenge to do so, at least. Up to 56% of these errors are related to miscommunication during patient and the clinician's encounters. So the definition was well covered. Diagnostic error is diagnoses that are delayed, wrong, or missed. And as per research, 79% of diagnostic errors are related to patient clinician encounter and again, and up to 56% of those are related to miscommunication, as per another study. Dr. Ahmed shed the light on the nature of diagnostic error in the emergency department, and as per a study, up to 16% of the error happened in the emergency department, but the highest number, as I mentioned and probably covered before, is ambulatory care with 56%, followed by inpatient by 28%. The takeaway message from the percentages is setting our priorities. And we know that we have scarcity in our resources, whether it's money, time, or expertise. But if we focus on improving diagnostic error, I think if we focus on ambulatory, we'll probably be able to reduce it by at least 50%. You're sharing from your end? Okay. All right. So I'm gonna stop then sharing from my end, and I'll give you control. So if you can go please to the next slide. Thank you. So again and again, communication breakdown are emerging leading of preventable cause of diagnostic error, but this is part of the whole preventable harm that occur in healthcare. And we know that there has been a lot of studies that linked preventable harm to communication failure in all of its forms, whether it's miscommunication, delayed in the communication, or even lack of communication, whether we're talking about verbal communication or documented communication. A lot of studies have linked the miscommunication that resulted in harm to system failure. This could be a good news for us, because whenever we mention system failure, that's something we can really fix if we redesign the system in a way to be mistake proven. So as you can see here, the majority of the failures or the breakdown in the system that resulted in harm, whether it's diagnostic error or other type around the system. System also inclusive of communication breakdown, and little to that, probably percentage between 10 to 15% to failure at the sharp end. So looking at how our system is designed, how our processes are designed, we can definitely tackle this and reduce it significantly. Can you please go next? Okay, so communication, to understand how to fix a problem, you need to understand the component of it. So I'm sure most of you are aware of the component of the communication in general, but if we break it into 3 phases, we know that communication entails of message transmission, message reception, and message acknowledgement. So the breakdown of communication can happen at any of those stages. We could have breakdown in the message transmission that include failure to transmit essential information for making diagnosis, delayed transmission of this information, or transmitted information that is wrong, ambiguous, or incomplete. When we move to the message reception, breakdown in that area occur when the recipient does not perceive the information is incorrect, or when the recipient to act on the message that can harm in many ways. A breakdown in message acknowledgement include failure to acknowledge recipient or understanding of the received message, or failure to state where action has been taken. And we know that great portion of harm happens because of failure to act. So although message acknowledgement is not strictly necessarily for data synthesis and follow-up action in all cases, acknowledgement facilitates concurrence among the parties, typically implies that some action will follow, right? And that can help us in double checking, that can help us in more proofing our system. So an acknowledgement breakdown can still lead to poor outcome because the sender may not be able to verify whether the message was received and the action actually took place. Next, please. Beautiful. I just want to make sure that we are at the same page. So if we want to work on communication improvement in the context of the diagnostic process, we need to break down the diagnostic process into few steps that can help us link it to where communication could fail, and then hopefully that can help in reducing the harm. So generally speaking, the diagnostic process has 3 main steps. One is data gathering, where data gathering occurs when critical diagnostic information is collected during a physician-patient encounter, primarily through history taking, physical examination, and review of medical record. There has been a lot of studies and published research that linked majority of diagnostic error to the time spent to take a patient history. And there were clear correlation between short history taking and diagnostic error. The second component of the diagnostic process is data integration, and it's a cognitive process involving physician judgment and expertise. Inadequate data collection would lead to errors in clinical reasoning and therefore in data integration as well. Whenever we talk about cognitive abilities in the science of human factors, we know that any distraction, any interruption can result in harmful decision. And we all know what healthcare system looks like, how we actually function, and the amount of noise and interruption that takes place is beyond imagination. The third component of the diagnostic process is verification of the diagnosis. So verification of the diagnosis entails the confirmation or rejection of diagnosis hypothesis by obtaining further data such as laboratory tests, imaging, or pathology specimen. And we know the nature of diagnostic errors that is really related to this area, whether it's the incompatible or wrong indication, probably result was not communicated in a timely manner, and there is a delay, and so resulted in harm by patient not receiving a timely treatment. Please, next. All right, excellent. So now that we somehow dissected the diagnostic process, let's now also somehow break down the communication process relevance to the diagnostic process. So a study actually was heavy on this, and they agreed to narrow it down to two forms of communication that are relevant to the two key processes in the diagnostic process, which is the data gathering and the verification steps. So one is called interpersonal communication, and that is the verbal exchange of information between two individuals. It could be physician-patient, patient-nurse, physician and nurse, and etc. The second one is the information communication, which entails the processing and management of data, such as notes in a chart, written instruction, laboratory values, imaging reports, or any aspect of data retrieved with an electronic system. We all need to remind ourselves that the goal of the communication in healthcare setting is not only intended to transfer information, but also to generate a response from the recipient, which is, we could maybe agree or disagree, sometimes does have a lacking in deal to many factors that we don't have time. But very important to ensure that the action and acknowledgement part of the communication chain is being taken care of. Next, please. So now let's learn a little bit more on some of the examples of the breakdown in communication that result in data gathering related to the diagnostic error. So the first three example has to do with the interpersonal communication against the three steps of the diagnostic process. So interpersonal transmission errors, for example, a patient does not inform her physician about a new growth in her breast. That is interpersonal transmission error. Interpersonal reception error is the patient informs his physician about a change in his mole, but the physician gets distracted by an interruption and fails to perform a complete history taking. Interpersonal acknowledgement error, the physician informs the patient to return to the clinic after an urgent X-ray, but does not verify that the patient understood, and patient get lost to follow up, leading to delayed diagnosis, which is really common, especially in oncology. And the reason why I'm mentioning those examples, because from experience, unless we have a real examples, we can't make sense of what's happening. All right, so I'll just continue. Now, the bottom three examples on communication breakdown is informational transmission error. A patient calls the nurse 2 days after a physician visit with continued symptoms of fever and chills. Information is recorded appropriately, but is lost before it reaches to the physician. So here we have a transmission kind of error. Information reception error. Information about patient continued symptoms is placed in the physician message inbox, but not dated. So physician confused it of something that had happened before, could not link it to the relevant patient. Last example on communication breakdown in data gathering related to informational communication is informational acknowledgement error. So a physician reads an email from a nurse about a recent change in patient mole. Interpersonal reception error. The patient informs his physician about a change in his mole, but the physician gets distracted by an interruption and fails to perform complete history exam. Next, please. Okay, I think you skipped one slide. Can you please go back? Okay, no worries. We can start from that one.
Ms. Nada, we still have 5 minutes.
Okay. Okay, next, please. Okay, so this is a model for improving communication around the diagnostic process that was proposed. So in addition to identifying the diagnostic steps that are vulnerable to communication breakdown, which are data gathering and diagnostic verification, and the type of communication involved, whether it's interpersonal or informational, we can further analyze the source of diagnostic error by examining the point at which error took place. So the two steps that you can see in front of you that entail the diagnostic process, whether it's data gathering or diagnostic verification, we can see a 3-level framework on improving the communication. This simple framework can lead to more than 12 type of communication errors that could happen at every step. So linking this to the previous examples, we can identify where communication error occur at the diagnostic process, and then redesign it in a way that can mitigate the error. Next, please. So to improve and patient safety, the Institute of Medicine had actually called for redesigning and error-proofing healthcare delivery system. One method for achieving this goal is to develop an electronic information system for the delivery of healthcare data. We all know that using digital and IT alone can definitely improve in big time, but we know that it's also introduced a new set of forms of failure. But some of the recommendation that is recommended by the IOM is that we need to develop electronic information system for data, for the delivery of healthcare data. We need to adapt and work more on utilizing standardized communication like the SPAR. We need to always have the readback verification to ensure the acknowledgement part of the communication, alerting for diagnostic test result management, tracking the consultation to ensure that it actually reached to the provider and they acknowledge receiving it. Many effort also by the HRQ around engaging patient and having shared decision making in the diagnostic process. Direct reporting of test result is also recommended, and reinforcing critical result transmission by more than just one method among the areas that was recommended. The AHRQ have actually recommended many different tools to improve the diagnostic safety. One of them is a toolkit for engaging patient to improve diagnostic safety. One is called Be the Expert on You. The other one is called 60 Seconds to Improve Diagnostic Safety. There is also team step SA, which is an evolving version of the team step training that focus so much in improving the diagnostic improvement by focusing so much on mutual understanding, leadership, and communication. Also, the patient safety culture survey had additional component for the ambulatory care setting that also focus on the safety of the diagnostic process. There are many recommendations and really adopt. We just need to prioritize, understand where is the common error area, and move from there. Next, please. So in conclusion, focusing intervention and diagnostic steps that are prone to communication breakdown could achieve a significant reduction in diagnostic error. So we, based on our reporting incident, studying our event, looking at published research, where is the part or the step of the diagnostic process that is more prone to a communication breakdown, and focus on that. Looking at the areas that had more diagnostic error, which is obviously ambulatory care, should be a priority. That's the area that we need to focus, and then we can really reduce it significantly. IT-based intervention alone, however, cannot assure improvement in communication. We are a human-driven industry, so we cannot neglect the part of humans. So a lot of human factor engineering integration should be there in the clinical areas, and whenever technology is being introduced, it should take into consideration human factors there. Data gathering problem may be the most common reason for diagnostic error, at least among trainees. So clearly, and that's based on a lot of the studies, so clearly training curriculum needs to further emphasize traditional history and physical examination for the future physician. As per the researcher, they believe that they tend to over rely on expensive and unnecessarily diagnostic tests. So thank you so much. I reached to the end of my presentation. If you click the next slide. Once again, thank you so much for giving me the opportunity to be part of this amazing curriculum and agenda. And I look forward really to coming up with collective recommendation that we can adopt based on the extensive work of all the presenters and the centers, and have a national strategy that transform this amazing conference into action and call for an actionable agenda. Thank you so much.
Thank you so much, Nida. Ms. Nida, for this very informative lecture. And thank you so much for highlighting the role of patients as being one of the system layers of preventing such type of errors. It was really an informative lecture, so thank you so much. So now we have all of the speakers, and we will see it's the time for a Q&A. So let's see what the audience have, what the questions. So I could see many thanks and appreciation from the audience for all of the speakers. And we have one question from Mr. Muhammad. He's asking why there is less interest in addressing the patient safety diagnosis in mental health setting. And this question is for Dr. Gordon.
My mic, but there's feedback. Do I need to do something to help? Should we having the feedback?
Dr. Gordon, if you're connected to two devices.
Is that working fine now?
Yeah, it's better. Thank you.
Great. So if I got the question correctly, why is there less interest in mental health diagnostic errors. And, I'd be interested in the questioner's perspective of where that's coming from. I think it's certainly true. I think there's many components of this. I think first we have certain stigma and bias about mental health that really makes us often turn away from those patients rather than lean into taking care of those patients. I think there's another aspect that has to do with trying to sort out symptoms. And, in the worst sense, patients' symptoms who have mental illness are often dismissed as due to their mental illness. So somebody has chest pain or headache, abdominal pain, and that's something that it's labeled anxiety. I think there's a lot of emerging research about how diagnoses are more likely to be missed in patients who have chronic mental illness. I think part of it is how we're trained to be able to listen to patients and be able to do that better. I think also we make the health system pretty hard to navigate. I think actually I would even say it's a nightmare to navigate. So people who have less abilities, other stresses in their lives, it makes things even harder how you get through to these telephone trees, lack of access. So I just think that there's a series of ways we need to look at this with sort of fresh lenses from the perspective of the patients, and even retrospectively learning from things that have gone wrong, hearing it from their voice. And then we talk about specific diagnostic pitfalls. What is it that would differentiate major depression from bipolar? So what are the critical features and how do we avoid those pitfalls? So those are just a few very quick subjective answers to, I think, a really important question.
Thank you so much, Dr. Gordon. So we have one question or probably a comment that's highlighting one of the risk areas that you have mentioned for diagnostic errors in the primary care center, which is busy clinics and shortage of time. So one of the attendees is saying physicians in busy clinics are ignoring proper history taking and assessment or are faced by insurance rejection.
Relationships with the patients. So I think these patients in some ways are often shunned, but we need longitudinal relationships where we can really get to know our patients. They can trust us, we can trust them. I think especially patients who are paranoid or anxious, continuity and trust can go a long way to overcoming a lot of these other issues that I mentioned.
Okay, thank you, Dr. Gordon. Let's see if we have any other questions. So I have one question to Dr. Kumal. Dr. Kumal, from your studies on the diagnostic errors in obs and gynae departments, do you think those diagnostic errors could be related to different regions, different areas, or do you think are those standardized internationally?
Yeah, thank you for that question. And it clearly sort of speaks to the contribution of the work system, which will be different in different places. And so I think while there will be some common buckets and themes of types of errors, how they manifest and the solutions I'm imagining will need to be tailored to the local environment, similar to how sort of other successful diagnostic safety interventions are targeted to sort of the folks and the systems that are involved with care. But I think it's really imperative for all of us to begin to understand how best do we capture these errors, learn from the giants in the field, like Dr. Schiff, and really sort of, apply what we learned there into OBGYN, because I think we can learn a lot very quickly.
Thank you so much, Dr. Kumal. So my next question is for Ms. Sophia. Ms. Sophia, I want to ask you regarding the value-based healthcare transformation in Saudi Arabia and the use of virtual...
I'm not hearing sound.
Could you hear now, Dr. Gordon? Not yet. So again, Sophia, my question to you is about the value-based healthcare and how does that relate to virtual clinics and to diagnostic safety?
So if we think about, so if you think about the formula of value, right? You always have to look into the outcomes that we provide following the treatment or the health we give to patients. And those outcomes are divided into clinical outcomes and the patient experience of the patient over the cost, okay? So if we think about, so telehealth or virtual clinics, they have proven to be quite effective when it comes to the agility of how we provide consultation to patients, and some specialties like dermatology, they've even gone as far as providing, some sort of diagnostics through those consultations. Now, from a patient experience perspective, obviously, if I don't have to leave my home to go to a clinic for a 10-minute consultation when I can have it online and have it through a virtual clinic, so right there, it's already a value, right? And over the cost, so there is, the cost of having a physician being, running like a clinic for hours. By having virtual clinics, potentially he will, they will be shortened, so they will have more clinics going on, and all the costs associated to, from the cleaner to the maintenance of the clinic, it's taken away. So overall, it sounds like it brings value. And I've been through that experience. So, I was in love by the fact that I didn't have to get out of my house. Now, what this entails, and as Ms. Nada mentioned and other colleagues have mentioned, every time we bring a new technology, we bring also a new set of dangers, right? And a new set of potential errors for happening. So in virtual clinics and remote monitoring and so on, what we need to be mindful is that this may require a new set of skills for the clinicians to be able to run safe diagnostics, right? Because, we know that it's never the same thing when you're actually capable of assessing a patient in front of you, or if it's a consultation for, something that it's more logistical than actually, for a disease. It's, it should be, from a cost perspective and value, it should be fine. But we just have to, as we move forward towards more utilization of automation and AI, virtual clinics, the virtual hospital we have at our MOH site, and so on. This, we have to be very mindful. Two things: a new set of errors may be emerging associated to those patients, associated to those new strategies and techniques. And in addition, a new set of skills perhaps will have to be deployed by the academia in order to overcome those chances for error. So I hope this answers your question.
Yes, absolutely, Ms. Sofia. Thank you so much for the answer. So one last question for Ms. Nida. Ms. Nida, you have highlighted the role of the patients and their families in preventing diagnostic errors. And you mentioned the 60 seconds tool and also the Be the Expert tool. So my question is to you, from your experience, have you implemented any initiatives or projects trying to engage the patients? And can you tell us a brief about the lessons learned of such activity?
Thank you. And I'll try to be very quick, because I know people are really leaving now. So the 60-second and the other initiative, to my knowledge, has not been implemented. Is a recommendation by the HRQ, but I think this is a great opportunity that we can promote for it more through the Saudi Center of Patient Safety. However, there has been a lot of other activities that focused on patient engagement. There is an initiative I know that at KFSH called Nothing About Me Without Me, was led by the experience department and well supported by the leadership there. Also, engaging the patient in terms of the decision making, something also the Saudi Center of Healthcare Accreditation Sibahi advocates so much into that. There are a lot of standards that audit organization against patient engagement, whether it's through the patient and family education or through the consent taking process and the documentation. There are a lot of other activities, and I don't want to promote for specific one. However, we're not there yet where we want to be in terms of engaging patients. Still, we are behind, and the data and the statistics indicate that very well. There is a clear language barriers between us healthcare providers and the patient, whether it's the technical language of it or the meaning of what we do. We're in rush, we talk fast, we don't give time for patient to even ask a question. So this area required a lot of work, and the more we engage the patient, the more the healthcare is safer. And this should be taught at a different university, not something that we practice after we hit the ground in the clinical areas. There is a huge gap between the healthcare industry and the medical practice that we hope to bridge that gap, inshallah, sooner, I believe. Thank you so much.
Thank you so much, Ms. Nada. And I think if we continue to ask questions, we wouldn't end the session of today. So we have to end it. However, I would like to thank you all at the end of the session for your knowledge and experience, and for sharing all of that information with the attendees of the conference. I would like also to thank Saudi Patient Safety Center for creating this platform for sharing the knowledge and experiences, hoping to improve patient safety nationally and globally. Really thank you from everyone who's attending the conference. And I would like to close the second session and remind participants to the second day program that's going to start tomorrow, inshallah, at 7:30 a.m. is going to be the registration. So see you all soon, and stay safe. Bye.